You're listening to the We Are Libertarians podcast network. Find all of our shows at wearelibertarians.com.
Episode 58, The Paradox.
Welcome to The Paradox with your attending, Dr. Eric Larson. He is a practicing anesthesiologist and clinical assistant professor at Michigan State University College of Human Medicine. Listen in as he takes you behind the scenes of what practicing medicine in today's ever-changing world is like with another doctor. The Paradox is a fun and accidentally informative show for physicians, patients, or anyone who has ever found themselves in a waiting room.
Welcome to The Paradox. I'm your host, Dr. Eric Larson. Thank you for joining me as we explore the U.S. medical system in a fun and informative format where you can learn about what physicians face through expert analysis. And today's expert is Dr. Wayne Jonas. Dr. Jonas is a practicing family physician, an expert in integrative health and healthcare delivery, and a widely published scientific investigator. Additionally, Dr. Jonas is a retired lieutenant colonel in the Medical Corps of the United States Army. From 2001 to 2016, he was president and chief executive officer of the Samueli Institute, a nonprofit medical research organization supporting the scientific investigation of healing processes in the areas of stress, pain, and resilience. Today's discussion is going to focus on self-care, the integrative health, and why that matters to you, why it should matter to physicians, how one could incorporate it into their practices, why it's not taught more at medical schools, why you don't see it very often in physicians' offices, and we're also going to get into a little bit of the military and VA healthcare systems. I don't know a whole lot about it, and I'm not sure how much you might know either, but I thought it would be interesting to have someone on who has experienced both systems to talk about the differences, what he thinks the problems and the advantages are of such a system, how they can incorporate greater sweeping changes to potentially involve integrative health and large system changes to improve healthcare for veterans and active military personnel. And then, of course, the corollary is, can you apply this to the civilian sector, aka us? Links for the show can be found at theparadox.com/058. Also, I'd recommend that you go to your favorite podcast player, and if you've not already, please subscribe, leave a 5-star rating at your favorite podcast player, and continue to share the show with your friends and families and colleagues. If you feel so inclined, you can go to the Patreon support page at patreon.com/theparadox. That's PARADOCS. And there you can become a monthly patron to the show, get a shout out, potentially some other content, and an easier way to get a hold of me if you have any show ideas or comments. You can also do that through the email at the paradox.com website. But without further ado, Dr. Wayne Jonas, author of How Healing Works and former director of the Samueli Institute, which studies integrative health. Enjoy. Well, it's a great pleasure. I have Dr. Wayne Jonas here. And Dr. Jonas, thank you so much for joining me tonight.
Well, thank you, Dr. Larson. It's really a pleasure to be here, and I appreciate both what you do to get the information out that you do, and hope I can contribute to that.
Right, and we were talking a little bit beforehand, and so you're worried that you're going to be interviewed by two docs, but you did not realize you were half of the pair.
I'm the other doc, right? We're the paradox. That's great.
So I wanted to kind of introduce you a little bit to my audience, and you've had an extensive history in practicing medicine within, I guess you'd say, the government, or at least with the military, in Walter Reed, and then some appointments doing, as a family practice physician, you're working with integrative health. So why don't you explain to people, I mean, I think everyone knows what a family practice physician is, but kind of give a background of what you mean and what most people talk about when they talk about integrative health and how that sort of affects how one would practice.
Yeah, so thank you. I stumbled upon this in my journeys actually through the military originally. So I was, am a regular family practice doc. I still see patients in a military hospital and practice standard, primary care. But during my journeys, I was at Walter Reed, and then I was at NIH, ran the Office of Alternative Medicine. I ran a WHO, World Health Organization, traditional medicine center, which looked at practices from around the world, such as Chinese medicine and Ayurveda and other types of things. We were looking at it through, Western scientific lens and trying to do research in those areas. And I actually got exposed to many of the so-called complementary practices that now I think some of which should be integrated, some of which shouldn't be. When I was in Germany, I ran a hospital in Germany as a military doctor and worked closely with the German physicians in our area. They did all our emergency transport and everything. And they were using, this was back even in the early 80s, they were using acupuncture regularly for pain. They were prescribing herbs for depression. Homeopathy was prominently done. And so, I thought, gee, do they have a bigger evidence-based medical bag than I? They seem to be rational people, but they're using kinds of stuff that I either didn't hear about or just heard about as sort of non-science and nonsense. And so I began to sort of inquire about this. I went and started to study with a little bit of them. I began to look into the research in these areas, and that exposed me to really a whole world that, I hadn't seen in my standard medical training. It really did open up my lens to viewing a broader view of how healing happens. And over the years, I've realized that broader lens is not just putting more things in your medical bag, but it's actually a perspective change. That many systems of care, especially some of the older traditional systems, including Western medicine, Hippocratic-based medicine from the West, was much more holistic than it is today, and much more holistic than what I viewed. That it acknowledged and incorporated into care, the whole person, meaning their environment that they were in, their lifestyle and behavior, their social and emotional components, their mental and spiritual components. And I had sort of found myself on a treadmill of, coming in and prescribing pills and procedures and not really connecting with the other aspects of my patients, which the data now shows and that we know quite well significantly influences health. In fact, we know that things that go on outside the doctor's office, lifestyle and behavior, especially for chronic illness, social and emotional environments, social determinants of health, are a much bigger influence on actual health outcomes. Some estimate up to 80% more than healthcare. And so, healthcare, seems to be contributing a smaller and smaller amount to the improvement of our population's health in chronic diseases, especially. Now, if you're dying, you've got infection, you've got trauma, you got something needs to be removed, cancer, or, acute heart attack or something. We're stellar. We can keep you alive, right? And we're really good at that. And who doesn't want that? Everybody wants that. But when it comes to preventing and improving health and chronic disease, we sort of lost our way. And so I began to look into how can we regain that? How can we get back to the path and reintroduce the concept of healing into medical care and not just deal with the pathology and the pathogenesis?
Yeah, and that's interesting. And what's funny about it too, I think, is that if you think about it, and if someone didn't have any medical training, well, like a number of people who are my audience, of course, it's not really revolutionary to think that there's far more that affects your health than how your limited visits to the hospital or to your physician's office. I mean, I think we all know that if you don't take care of yourself, you don't sleep, you don't eat properly, you don't exercise, you don't do some basic things, that your health is not going to be good. And no matter what kind of doctor you have taking care of you, it won't really matter. And so I think, on a basic level, everyone probably fundamentally understands that.
Well, I think you're right. They do understand that. And the recent survey, we recently did a commission to survey the organization I work for, Samueli Foundation. We recently commissioned a survey from the Harris poll, from the Harris organization, to do a poll of both physicians and patients to gain some sense of what their beliefs and attitudes were about these kinds of behavioral self-care approaches. And what was remarkable about it was that the physicians, even more than the patients, believe it or not, really felt like self-care was a core part of not only what needed to be done, but what physicians themselves should be talking to their patients about. But then when we ask the patients, did the physicians talk to you about that? A very small percent actually said that. They said, well, I'd love to talk to my physician more about, the behavioral part, the lifestyle part, the non-medical part in terms of its impact on the prevention and treatment of my illnesses. But they don't talk to me about it. And then when we asked the physician said, oh, I did talk to him about it. And so there's a real communication gap going on here between docs and patients about what is self-care, how do we get it, and are we really communicating and connecting about it? And I think part of that is because we don't actually have a system that really, where the healthcare system, the medical system itself, really supports patients in that process. Yeah, maybe physicians did mention, well, you got to eat healthy, and you should get sleep, and exercise is important. But did they really provide them with resources to make those kinds of changes, or did they really connect to the community components that were needed to do that? Because we all know that behavior change like that is not easy. And so if we believe it's important, as 96% of the physicians said it was, then why don't we structure our delivery system so that we make sure that happens? And I think that's the big thing, is that we need to redesign our healthcare system in a way to facilitate what we know are these underlying determinants of health, if we expect healthcare to actually be part of the solution of delivering health and not part of the problem of increasing costs and poorer outcomes. So.
Let's back up a second, and why don't you just define what self-care is? Because I think I'm reading through your materials, but even when someone mentions what self-care is, it may not be clear what exactly it is besides like eating right and exercising.
Well, those are the core things. There's 4 things that I teach my residents and that I do in my practice, 4 simple questions around self-care. And they have to do with nutrition, they have to do with activity, physical activity, and they have to do with sleep, and they have to do with stress and stress management. And what are you doing to manage those things? Those are the core activities that we know impact diseases like hypertension, obesity, diabetes, cardiovascular disease. Even in increasing evidence shows that cancer and dementia, mental health, are influenced significantly by those types of behaviors. And so those are the key questions that should be asked to patients about, what are they doing in these areas? And then, can I help you, or particularly, can my team help you? Because actually docs aren't very good at helping patients do this. But can my team help you enhance those kinds of behaviors in your life? And so that's, the data shows actually from population health studies, that's about 30-40% of chronic disease determinants are due to those 4 factors. The other 30 or 40%, which make up about 80% of the determinants of health, are social and economic factors, where people don't have the ability to actually engage in those behaviors because they're in a food desert, for example, or don't have transportation, or homeless, or increasingly don't really even have the basics that are needed in order to engage in those kinds of behaviors. And so increasingly healthcare is can't solve those problems. We can't solve the homeless crisis, but we can ask questions about food and food insecurity and that type of thing. And we can then set up systems that connect to delivering on those social needs to do that. And there's a number of models that have done this. Geisinger, just a big health system up in central Pennsylvania, just got back from visiting them. They have set up a whole healthy foods program for poorly controlled diabetics that also have food insecurity, and they provided actually prescriptions for healthy food that was delivered by the local food banks, and then some education about how to use it. And they found that simple approach markedly reduced their hemoglobin A1C increased increased weight loss in that particular group, and it actually lowered costs because they were now developing less and less complications, less and less healthcare needs, and less medication use that was needed in those areas.
Yeah.
And so we somehow need to build into our delivery system questions about those underlying personal determinants of health for a patient, and then make sure that we have a system that's set up to either help deliver that to them or to connect them to the resources that are going to make that happen.
Sure. And I think, when you talk about self-care, when you talk about holistic medicine, I think it's pretty easy for a lot of physicians to sort of go down the quackery road, like, well, this is all kind of, acupuncture and all these complementary medicines. But I think it's probably important to think directly, like you mentioned. I mean, it is well known that a lot of these activities, which are simple and free, like going for walking or something like that, they do significantly decrease disease rates, whether it's Alzheimer's or obesity and diabetes. And so it's probably not very smart to poo-poo them.
Yeah,
as physicians,
exactly.
Especially when they're right. I mean, especially when they're fairly easy. I mean, you obviously are not write a prescription for them. You obviously have to find a way to make it feasible for the person to be successful, and that's part of the trick, I suppose.
That's exactly right.
To just discount them is not really a good strategy. And I always have thought this ever since probably when I was in residency, that you have plenty of time in the OR to sit around and think,
right.
The surgeons, especially like a medical student closure, as much as we do, like if you do a surgery and let's say you take out someone's appendix, fundamentally you have removed the pathogen, the problem, but whether the person gets better or not is entirely dependent on the patient. I mean,
right.
There's some, I guess you could say, not entirely, but maybe almost all of it, right?
Yep.
They have to have they have to be healthy enough to survive the surgery, to not develop an infection. They have to eat the right nutrition afterwards to make sure they can have the cellular reconstitution of their skin or whatever. And so without that part, you can do whatever, you can do all the right things from a medical standpoint and still fail, right? I mean, so it is entirely dependent on the patient being able to heal on their own. And so I think by extension, it makes sense that chronic conditions that are problems for people would, naturally have a lot of it has to do with how the patient how they can heal and get through those things as well.
That's exactly right. And, I think physicians underestimate the importance, not the importance, but the influence that they can have and some of the simple things that they can do to markedly impact this area, that, traditionally they haven't thought as their area of expertise. There's a whole science of behavior change. It's actually been well researched. We know how people get ready for behavior change, stages of readiness, etc. There's an entire science to do that. None of us in medical school learned how to do that. Maybe we learned a little bit about motivational interviewing or something like that, but we really didn't learn about the whole the science of that. But we could actually bring that into our practices, using properly trained health and wellness coaches, for example, group approaches, that type of thing, that actually does effectively help people make those kinds of changes. There's also some very simple things we can do. Before you started this podcast, we were talking about a simple self-care toolkit that was brought into the perioperative setting. So this was given to patients before they went into surgery, and it involves some simple self-care things, education about what to expect, what to do before and after the surgery. It involved imagery. It involved some little acupressure bands and a couple other things. And simply giving, we did a randomized controlled trial in which we simply gave patients this self-care toolkit. And we saw remarkable improvements in post-operative recovery, less pain, less nausea, less medication use post-operatively. And in 2 weeks out, we even saw lower inflammatory markers in this. And so these are simple things that physicians can do to incorporate into their practice. And I put on my website a bunch of tools that others, those in primary care and other care can use to begin to implement those kinds of questions and those kinds of treatments into practice. So it is possible to do this. It's possible to do it. It's possible to have a big impact. And the motivational part is really one of the physician's main jobs. They need to ask the questions, they need to emphasize it, but then they also need to set up, their team to support and assist the patient in doing this. And if the patient is successful in even one small thing, then this empowers them, and then they're on the road to healing, right? And then you can bring in other things into that process. It's not just give them, a diet sheet and say, here, eat that. There's a great, I'll just mention one other thing. There is a great orthopedic practice down in Austin, Texas. It's part of the Dell Medical School. And they have embedded into this orthopedic practice social workers to look at mental health, nutritionists that look at weight and diabetes control, complementary practitioners that provide chiropractic and acupuncture and other types of things. And when a patient comes in who, is looking for a knee replacement or back surgery or something like that, they first assess them in these other areas. And then if they can lower the BMI, if they can improve their hemoglobin A1C, if they can, their diabetic control, if they can improve their mental health and engage the patient in their own self-care and then do the surgery, they get much, much better outcomes. So much so that they've taken full risk and said, we will pay for anything we can't do in a bundles per patient care for this area. And they've shown that they can reduce costs, make money off of it, and improve that by having such a holistic approach, even in a perioperative and surgical setting.
Yeah, it's interesting because you have highly motivated patients at that point, and when I talk to orthopedic surgeons, they'll mention that the patients who are active and they will do exercises to try and strengthen their leg, for instance, before a total knee replacement. Right. Even for doing that for a couple of weeks, trying to improve their strength in their thigh, quadriceps, and that it makes a tremendous difference afterwards in their recovery.
That's right.
They just do so much better.
Right. And you've got to give people hope. You got to realize that they have the power actually to improve their own outcomes and support them in the process. Right. And when they do that, if they get engaged and empowered, then they will do this. So it doesn't take a whole lot to do it, but it takes a team to help them do it.
Well, it's interesting. When I always interview patients, it's funny now that I see a lot less patients who smoke, for instance. Yeah. When I started my practice, there were a lot more people. Just less people smoke now than in the past. Although more people probably use marijuana than before.
Right. They're going over to other things. But yeah.
They're smoking different things. But as far as smoking cigarettes, when especially culturally, if you ask someone if they're smoking, they're only thinking about cigarettes, right?
That's right.
But when I'll ask people they smoke, they say, yes, they do. I'll say you should stop. And I kind of joke that, well, it's my primary care that, I've only got 5 minutes before I go back to the OR.
Right.
But I've noticed that if I have some sort of evidence, and so I'll see a patient who might be in their 50s and their hemoglobin is elevated, might be 17, these guys who are basically showing signs of early COPD, right? Because they've got elevated hemoglobin, which suggests oxygen starvation, and they're ramping up their hemoglobin. Yeah. And I will say, you need to stop smoking. They're like, yep. And I'll say, I'm concerned because your hemoglobin's elevated, which suggests that you're in the early signs of COPD. And then it's amazing the different, like the look on their face, like, oh, you're not. It's not like it's no longer a joke.
Yeah.
And I don't actually know if it's more effective. I tend to think it probably is. I think it's more likely that they'll do something. I try and convince them if you stop smoking at least for 2 weeks, it's going to help with wound healing and things like that. Maybe once you're beyond there, maybe then you can stay quit and save yourself some money at a minimum, right?
No, that's exactly right. Well, what this Dell Orthopedic group does that's, focused on value-based whole person care is that they say, okay, we're not going to do the surgery until we're able to get you in better health. Okay. And then they have nutritionists and they have, physical therapists, and they have the chiropractors, they have the mental health folks, the smoking cessation folks there to actually get them to that point. And they'll work on them for maybe 2 to 4 weeks and then do the surgery. And the outcomes are so much better that they actually save money on the surgery and they save money in the long run compared to just saying, well, we'll just take you and see what risks happen. And they make money actually off of it. It doesn't cost that much because they save so much money off of doing that first that the overall costs are less.
Right. Well, it's interesting because, even in a lot of the anesthesia literature, we're finding that if there's some way you can reduce the stress on day of surgery, like let's say you're using a multimodal pain approach where you're just not using opioids, you're using, acetaminophen, you're using ketamine, you're using like a gabapentin or something like that, and you're using regional anesthetic techniques. Yeah. That you will see a difference in the stress indicators, like you mentioned, the hormones, even months out from the surgery, which is a significant difference. So, it has an effect. I guess it's probably hard for us to quantify exactly what, from an outcome standpoint, how much difference it makes. But if it's having that long-lasting effect, it can be nothing but helpful.
That's right. Now, imagine combining those kinds of drug approaches to reducing stress physiological response with ones in which the patient can engage in and do themselves, like which was in the self-care toolkit. That's primarily what it did. Yeah, right. It helped the patient reduce their stress. Mm-hmm. They lowered their cortisol, they slept better, et cetera. Combine those things in an integrative fashion, and you've got integrative healthcare.
So, I think it's right, and it's fairly simple, but I think it's pretty clear that these things are the low-hanging fruit, let's say. They're fairly inexpensive. Handing out a self-care, package is really cheap. What do you think the impediments are for introducing more self-care in the medical schools and training? why do you think it's not taught? I didn't learn any of this stuff. Yeah. In med school.
Yeah, I think when we did the survey, what the physicians said is that, because we did physicians and patients in this survey, and they said the problem was time. They said, I don't have time to sit down and have these conversations with patients. I don't have time to practice self-care myself, and I don't have time to incorporate it into my healthcare visit. I don't get paid for that time. And so, and that was the thing that they primarily complained about. The reality is they're spending that time elsewhere. They're spending that time later on when they see the patient back and they haven't done well. Yeah, right. And so it's not really a matter of just time. It's a matter of how do we design the time and deliver it. And also, we also have this sense, physicians tend to be a bit arrogant. They've maybe deserve it because they've gotten the most education, but we tend to work alone. We say, oh, well, I've got to write the orders and somebody else carries it out, so I don't have time to actually do this. Well, the reality is if you have your team organized so that you have somebody trained to be the kind of health coach to support the patient, but they're your extension, right, in that area, then it doesn't require that much more time. You can actually say, I think I want you to do this, meet with my health coach to engage in that process. And then the health coach can engage in the evidence-based approach to try to make that behavior change happen. So it's time, team, and tools. If you organize your team right, you incorporate efficient tools in those areas, it can be done. It's time if you think you have to do it all. And yes, that's going to lead to burnout. There's no question about it. And if you then have to do all the documentation, the administrative part of it, which, docs are saddled with more and more, and you don't have someone that can help do that, then that's just going to pile on. And burnout, as was actually 25% of the physicians in our survey said literally burnout was the reason they couldn't engage in self-care. And so it's really redesigning the delivery of what you do in a way to make the time more focused and effective on what the underlying determinants of health are.
Yeah, I feel like the healthcare system and the way the third-party payer system, whether it's government or commercial payers, really tends to a system. It's still volume-based, right? It's still as many patients as you can see is how you get compensated to in order to hire the people who help you, take care of people. And so, you're really strapped for time, and to try and find some way to carve out time to. I think I watched good examples. I watched a video on your website where you talked about journaling. Yeah. And you just told patients, that they have to write down daily sort of how you feel, and that over time they feel like they have more control over their life and sort of their emotions, and just helps them take, better care of themselves. But even that exercise of teaching someone how to do it probably takes you, 5 minutes, 10 minutes? And that is something that's going to eat up an entire time, because most people have 10 minutes with their physician. So if I'm a doc coming in, you're coming with hypertension, I know that if you had a better handle of your stress, that might help your condition as well. But I don't have, I can choose either to, write a prescription for an ACE inhibitor or,
Right.
and talk to you about hypertension, maybe diet real quickly, or to try and do a thing of journaling. Well, they probably all have value, but I'm going to say, well, I don't get paid
Yeah.
in some ways for doing the journaling, right? And so it's a decision that's going to always be the same. The outcome's always going to be the same for the most part for the practice. And it's to the detriment of the patient probably, and I would say even the physician, because you're probably not delivering the kind of care that you'd want to, but you're strapped for time.
That's exactly right. Well, and of course, time is simply our surrogate excuse for money, right? And you've said it right here. I'm not going to get paid for it. And so I've got to do what I'm going to get paid for. I'm going to get dinged in my system, in my practice, in my wallet, etc. And so I'm driven. So we have to have a system that will cover the things that produce health and that the evidence shows produce health. And so we don't keep doing the things that don't do that. And yes, we're literally trapped in a system that pays for what we get, right? We pay for waiting until something happens that requires an acute intervention, and we get paid a lot to do that. So we're going to keep doing that, and that will prevent us from overall in the healthcare system from saving the money from the prevention, self-care, and even disease reversal kinds of things that can happen if we spent the time to engage with the patient. So, I work in a military clinic, so you can, in some ways it's a little bit easier with that. It's a capitated system. I still have to document, with coding my RVUs and all that kind of stuff. But it doesn't impact me immediately because I'm in a capitated system. And we have set up in that system, and this is sort of value-based care. This is where that all the policymakers and CMS and HHS, Health and Human Services, and others are all saying we have to go from volume to value. Well, I work in a value-based system, and so we've set up, for example, for our chronic pain and opioid use patients, an integrative whole person pain system. And we sit down and patients come in and we'll have 5 or 6 patients that will spend the entire morning with our team. And I'll get to sit down with them in some cases for an hour, and I'll find out what matters to them. I'll ask them what matters in their life. Now, these are patients that have had back pain or multi-component pain or fibromyalgia, and half of them are on chronic opioids that we're trying to get them off. And they've seen everybody. They've gone to the surgeon, the pain clinic, the anesthesiologist, you name it, primary care docs here and there, and alternative practitioners also. But no one has really sat down and organized how do you engage in the non-drug approaches effectively, and how do you engage in the self-care and behavior approaches that are going to improve your sleep, which will improve your pain, improve your stress, will improve your pain, reduce inflammation from, the smoking and the sugar that you're eating in those areas. Yeah. And we will sit down and we'll spend the time with them, with health coaches, to do that. And then when they engage in that, and we've looked at some of this data over, for people that have been on this, and they've spent a lot of money, they've seen a lot of people, and then now they'll begin to get off opioids, they'll begin to get reduced pain, et cetera. I saw a lady the other day who had 10 years of chronic low back pain, multiple interventions, stopped her job because of disability issues. And she was attempting to stretch her back. She'd gone to physical therapy, but then that had been buried. Was on several drugs, and including mental health drugs because they told her she had depression, etc. And we got her engaged in a self-care program that involved therapeutic yoga, which is one of the evidence-based approaches that the American College of Physicians has recommended, by the way, in their guidelines for chronic back pain. And we got them, we got her linked up with a properly trained therapeutic yoga practitioner. We set her family up to allow her to do that. We then supported her with a health coach, and we have a behaviorist in the clinic and then got the pharmacologist involved to help manage her, her drug approaches. She engaged in this now we did a couple of other things that helped with acupuncture, helped with acute pain, that type of thing. And over a period of about 3 or 4 months, she was able to reduce her pain down to a level of 2, start to function. In about 6 months, she says, I think I'm going to go back to work in those areas. Now, she'd spent 10 years working with her pain, getting worse and worse and worse. And so, we spent time with her, no question about it. I sat down with her for an hour and helped organize the team to do this. But when we were able to support her in that process, she started on her healing journey and she got better. And that would have saved her a lot more time and more money than the healthcare system would have delivered over the next 10 years had she continued down the same path she was on.
Right. It reminds me of our computers in our office, which this will actually make sense in a second.
Yeah.
So about 10 years ago, we had the Fix-It guy who come in, and we have a bunch of mainframe servers in our office for all our billing, and there's things go awry all the time in IT, as any person who's in IT listening to this, right, will know. And there's always someone there kind of fixing things.
Yeah.
And what we would pay this person hourly based on, he had to come in and fix the server on Monday, and then Thursdays come in and fix the email system and whatever. And then we had another team come in, and they said, hey, we want to take over your IT services. Our goal is to never be here. Our goal is to get this thing running smoothly. So you pay us, and we'll be here to help if there's something goes wrong, but we're going to help you and set everything up so that it runs smoothly, right? I mean, there's still problems from time to time, but overall, it's a much better experience. Our business runs much smoother, and the IT is better because their incentives have changed, right? And I feel like in medicine, it's the same way. That for most of medicine, it's that volume based. And the problem, of course, is if we were to try and switch to a value based system, which is, I think everyone intuitively thinks is a better idea, that what is value for, and that has to really be defined by the patient, unfortunately.
That's
I think,
right.
You can try and find metrics that will, broadly encompass populations, but we're all individuals who make up a population. And if I'm not satisfied with the value I'm getting from a specific provider, then I'm going to find it, no value in there. And so, I think the big struggle with the healthcare system is really to try and find a way for patients to take control of how they are taken care of. And I think, ultimately, physicians probably, especially primary care physicians. I mean, I think with specialists, you're going to be more episodic care generally,
right.
Unless you're a cardiologist or nephrologist or something.
Yeah, that's right.
Right. And that you just need to design a system in which case the patients are controlling things, which is not how it is now.
Yeah, no, that's exactly right. And the Institute of Medicine, now the National Academy of Medicine, came out with a whole report 2 decades ago called Crossing the Quality Chasm, which was about how do you get high value care in healthcare. Yeah. And their number 1, 2, and 3 recommendations were basically put the patient in the driver's seat. And out of this came the movement called patient-centered care. And we still haven't figured out how to do that. And so how do you do that? Well, guess what? You ask the patient what's important to them in their life. And then you hook up your healthcare support processes to try to accomplish that. That's value, right? That's patient-centeredness. Mm-hmm. So on my website, I've delivered a whole bunch of tools for healthcare systems and also patients to start and do something what I call as a hope note. And now, we all do the SOAP note, right? In medicine, subjective, objective assessment and plan. That's, that is trying to get at what's the matter with you and what's the diagnosis and the treatment. Well, what I recommend is that we have to do that. We have to know what the diagnosis and treatment is. But then for chronic illnesses, let's do a hope note. And this works actually in the acute setting too. And HOPE stands for Healing-Oriented Practices and Environments. And it's actually a set of questions that you can do. And I find I can do this. If I know the patient already, I can do this in the same time that I would spend a regular office visit. I can do it in 20 to 30 minutes, where I ask them about what matters in their life. And I give them a little questionnaire ahead of time so they know what the dialogue is going to be. and they talk about what they're doing to try to help themselves stay healthy and where they're interested in working. And out of that, by the end of that visit, we talk about their behavior, social and emotional component, even the mental and spiritual component, what matters to them, right? And then their physical environment. And then we come out at the end with the framework for doing a personalized health plan. And you can do that within a few minutes, and then we have resources to then support them in accomplishing that plan. So it's very doable. So I recommend to everybody they do a Hope Note, do a personalized health inventory, and they will be doing whole person integrative care in a way that addresses the core issues we've been talking about.
Yeah, I've interviewed a number of direct primary care physicians, and I don't know how familiar you are with that that approach to delivering care.
Yeah.
And I feel like this is sort of the way they practice in some ways, because they have a lot more time for their patients. They get to know them better than you do in the, I hate to call them mills, but they sometimes seem like that, where you're just trying to burn through patients as fast as you can, have mid-level seeing all the patients, and just try and get as many visits as you can through. And so that they have, and the incentives are aligned because the patient they're paying for the service. And so for them, they're not going to be there if they don't think it's a value to them. Right. And that way they're making sure they're getting, it's just I think it's a better way at how you restructure the entire healthcare system. I don't know, but I mean, I think that's certainly a good alternative, a way of sort of making it a little bit easier to try and incorporate the way you want to practice and the way the patient wants to have the relationship they want with their physician.
Yeah, I think that's right. I just gave a talk up at the annual Direct Primary Care Conference a couple weeks ago. So, I think you're right. Yeah.
Okay.
How do we scale that type of relationship-based care? I think that's the key question, isn't it? Yeah.
Yeah. Well, and of course, the number one satisfier for physicians, as I say all the time in the show, is your relationship you have with your patient.
That's right.
And so anything you can do to make that better is going to make physicians happier and less burnout, less problems.
That's right.
The system. Are you currently employed by the U.S. government?
I'm not.
The military, or are you reservist?
I'm not. I'm practiced in the military. I was in the military for 24 years and did all kinds of different things and practiced the entire time. And but I now am a volunteer physician come in and work in the integrative pain clinic at Fort Belvoir. So I'm not employed, but I practice there. I'm credentialed there. I bring in a lot of the integrative approaches into that pain clinic. It's a very large family medicine residency program, training program. So we train residents there. I'm on the faculty at Georgetown and the Uniformed Services University, so I teach medical students there, and also at University of California, Irvine, which our foundation has just given a large grant to change its entire healthcare colleges to more of a whole person integrative approach. They just started that process at UCI. And so I see students and I see patients at those places.
The main reason for asking that question is I just wanted you to comment on the medical system, because maybe people don't know, but there is obviously a different system within the VA and within the military, right? They're different. Are you familiar enough with the VA to comment? What's the difference between the military, the active military system, and the VA as far as care, or are they the same? Yeah,
no, they are not the same at all, and I'm very familiar with both of them. I take care of a lot of veterans also, and I currently advise the VA actually on some of its whole person care system through a federal advisory board that I sit on. They're very different. I mean, the VA is also a capitated system, meaning they pay for, the patient care, but also have to document their workload. So they do an RVU-based system, so they have to code things and all that stuff. So there's sort of both the DoD and the VA sort of sit in between a full value-based care and a volume-based system. They're sort of they got one foot on the dock of volume and 1 foot in the boat of value, and the boat's leaving. So they're trying to figure out what to do in those areas. But the VA has just created a brand new program this year. I think something that is really a radical transformation of how we could move a large system into the direction that we just talked about. It's called Whole Health, and if your listeners want to learn more about it, all they got to do is Google wholehealth.va.gov. And it is a restructuring of the delivery of healthcare that empowers the patient, educates them, and then brings the treatment part into alignment with that. It's really a very effective. It's new. They've set up 18 centers of excellence around the country to begin to kind of implement this, evaluate it, see what impact it's having, adjust it in a variety of different types of settings. And their plan is then to roll this out across the VA over the next 3 years, building on the success of those 18 centers of excellence. So that is an example of how a system could transform itself. There are civilian programs that are doing this. I mentioned the Geisinger program, Intermountain Health, certain parts of the Kaiser program are really doing this. And so, they're not military or government systems, but they're moving in the same direction.
Yeah. Well, and I mean, my experience, first of all, vets are the best patients to take care of. They are so much fun. Certainly as a medical student, that was I think the best experience was going to the VA, mainly because you had so much freedom to do what you wanted. I think it's sort of like the way medicine used to be back in the 80s, the training, from a training standpoint, if you're a medical student or a resident, or even the fellows, they have a lot, you're a lot of independence.
No, and that's right. And I was going to say, as our population ages and more people, largely because we can keep them alive, right? Medicine is successful in keeping you alive. So you age, right? As the population ages, more and more people end up with complex multi-component comorbid diseases. They have lots of different kinds of conditions. And it's this kind of whole person model that we need to deal with that. And vets are a great example of that. I don't see a veteran with pain in my clinic that doesn't have 2 or 3 other comorbid conditions like PTSD or depression or something, or diabetes or weight issues or something like that. And so, these things, we need a different way to approach that type of a patient.
Right. And I feel like when I've taken care of vets, they almost, at least the ones I've spoken to, they almost all would rather have their care not in the VA. And so,
well, they should look at the whole health program, because that's going to change things actually for the VA.
That's great, because
and in mental health, the VA is far ahead of the civilian sector in terms of mental health care. So I think it depends a lot on what they have, and the reputation of the VA not being very good, I think is a myth now, because they've invested a huge amount in process improvement, and you can get some of the best care for whole person and mental health in some of the VAs. Now, it's a big system. It varies. The quality varies, as it does in any large system.
Sure.
Some aren't very good, and some are, superlative. And so, so you have to pick like you do any place.
Do you find, I guess, one question is why is there a DOD, why do they have their own system, and the VA, why are they not combined, or is this a large-scale government problem?
Yeah, well, they have. First of all, they originated differently. Okay, I mean the DoD, and they have different missions. The DoD is it's much younger people, so less. You're in the DoD because you've got to be ready to fight a war, right? So your goal is to stay ready. You've got to stay fit. You've got to stay ready. It tends to have people that are not, as old, and so they don't have the same chronic diseases. They got to keep fit in those areas because they got to be ready to go. The VA is folks who are finished with that. Okay, so they've been there, they've done their service. They're no longer you need to be ready to fight a war. Sometimes they've now suffering from the consequences of having done that. We see that now with the veterans that have come back from Iraq and Afghanistan, and been blown up, and PTSD and all kinds of musculoskeletal issues, and they come back, and now they're getting older, and now they're handed over to the VA, and their goal there is, can we keep these people functional, healthy, et cetera. So it's different goals and different missions, and they are 2 different systems because they're trying to do 2 different things, both using health and maintaining health. So they're very, very different systems, and they have different goals. So they couldn't really be merged, I think, effectively, because we did we need to keep people fit and active, and then when they get old and can't actually fight a war, they should be sitting in the logistics room helping to direct it, but not out there on the battlefield trying to shoot down the bad guy. Right.
I understand. Do you think it would be better if the VA were if all the money that was spent to the VA was given to the vets to enter the normal sort of the regular market with the rest of the Americans, or do you think because they're veterans, there's I just feel oftentimes there's, with all the scandals, the shortage and the long wait sometimes, that they're not given the care they might, they probably deserve, sort of earned. Do you think they'd be better off sometimes in the commercial system, or do you think that these reforms are going to transform the VA into a better system?
I think we need to make sure we are investing enough resources in providing access to good medical care for all of our veterans. And if they're in a place where, they can't get that medical care for whatever reason out of the VA system, then we should make sure that they can get it out of the civilian system. And there's a current act called the Mission Act that is, moving in that direction. The key word in what I just said is good. Okay. The variability within the civilian system, especially for mental health, is worse than in the VA. And that's been documented. And in fact, the quality of general care has been compared between VA and the civilian sector, and it tends to be higher within the VA. Okay. And so if a veteran cannot get access to good medical care, they should be provided with medical care on the outside. But it needs to be good medical care. So that means the VA should be paying for high quality. So they need to evaluate and make sure that they're getting high quality care. The other thing is that the civilians very often don't understand the culture and the special needs that might be derived from a veteran. And so they have to have embedded that kind of care into their system to provide it if they're going to, optimally care for them. So I think if that happens in the civilian sector, if the requirements for paying for it in the civilian sector were such that they provided high quality care outside, then this would improve access for veterans and take care of veterans overall as a whole better.
Okay. Well, I really appreciate you taking the time to talk to me about SoCare and even the questions about the various military medical systems, which I'm not too familiar with. Why don't you tell just people, first of all, how they find more about you, and then actually, if you want to mention and I apologize, I didn't even know about your book until I was doing some research, but can you just tell briefly about how healing works and what the book is about, and then basically how people can find you, and maybe a little bit about the Samueli Institute real quickly, what they do?
Yes, so I wrote this book in order to describe in a clear and effective way what I learned from having really traveled all over the world, looking at a variety of healthcare systems through a scientific lens. Having been running the Office of Alternative Medicine at the NIH, a World Health Organization center, and having been trained at Walter Reed and actually taught research at Walter Reed on these areas, what I learned there and what I learned in my own practice is that taking care of the whole person and facilitating healing, what I call salutogenesis, the creation of health. Saluto is health, genesis is creation, and not just the pathogenesis, what I learned in medical school, the treatment of disease. Combining these into an integrative approach provides a superior system, and it in fact is the system that we need for chronic care management, in our world today. And so I learned these lessons. I wanted to be able to communicate it to the public, and so I wrote the book to describe how I learned this. And then at the end of the book, I write about how do you actually make this happen in the day-to-day healthcare system that we have today. And so we created tools to do that I use in my own practice, that I teach in medical school and residencies. And then we are supplementing those tools that I described in the book, How Healing Works, with additional tools on my website. And my website, simply my name, drwaynejonas.com, all one word. And we're constantly putting new tools onto that website for your average clinical doc and clinical system to put into their system to deliver whole person integrative health. There's a whole section that we're about to break out for patients so that they can begin to be proactive in this process, ask their docs, do an integrative health, do a hope note with me so that I'm addressing my own personal determinants of health and integrate that with the medical treatment. And so if there was anything your listeners could do tomorrow, they could go there, they could look at those tools, they can begin to implement those things, in their practice on a day-to-day basis. And we're always looking for more ways to make it easier for this to happen. And so if they come across any, they can email me. My email is on the website, drwaynejonas.com, and I'm happy to look at those and see if we can incorporate them and make them more widely available.
Well, thanks again for taking this time out of your night for talking to me. And all the links for the website that you mentioned, the VA article, and maybe other episodes that are related to this will be on the website at theparadox.com/058. Dr. Wayne Jonas, thank you so much.
Well, thank you, Dr. Larson, for what you do here, and thank you for the time and the great discussion. Have a good evening.
My pleasure. You too.
Okay, bye-bye.
Thanks for listening to The Paradox. If you like what the doc is doing, please subscribe and leave a review on iTunes or Stitcher. And share the show with your friends. Become a supporting listener to get access to special bonuses at patreon.com/theparadox. Show notes can be found at theparadox.com.